Everybody to today's acid base lecture. I'd also like to welcome the new first year fellows and the returning second year fellows. Today I'm going to, for the first year fellows especially, I'm going to give an introduction to clinical acid base diagnosis, and we'll give these talks throughout the year as you progress in your knowledge about acid base balance. So, as far as the current approaches to blood gas or acid base analysis, there's really three main approaches that have developed over time. The first is the Schwartz and Relman bicarbonate centric approach that developed in the 1960s, and that's what is typically used by nephrologists throughout the country. What also developed was a different type of approach that was generated by Astrup and Sigurd Andersen in the 60s, and it's called the base excess approach that you'll still see in a number of institutions as far as their blood gas results. Conceptually, this involves taking blood and equilibrating it at a PCO2 of 40, and then adding acid or base to bring the pH back to 7.4. So you're quantifying the amount of acid or base that's needed to be added to blood outside the body at a PCO2 of 40. That's what base excess is. And there are pros and cons with this approach, which is why it never caught on with most clinicians in the United States. And then there's the Stewart approach, also called the strong ion approach, that developed in the 1980s. This has been accepted by a number of nephrologists, mostly in Europe, and ICU people. The concept here is a different one, and that is that it's the net charge in a solution, which is what the strong ion approach refers to. Conceptually, you can think of it as sodium minus chloride. That difference is what is causally related to acid-base changes in blood. I've written a critique of this several years ago for any of you that are interested in reading it. So what evolved in nephrology and throughout the United States in general, in most medical institutions, is to use the bicarbonate-centric approach. And it's based on the concept that there's a buffer system called the bicarbonate buffer system. And it's important to know that there isn't only bicarbonate that makes up this system. There's four carbonated species. So one of them is CO2, which refers to carbon dioxide. H2CO3 is carbonic acid. Bicarbonate, you know of. And then there's another entity called carbonate. And it's these four carbonated species that are in any solution that is bubbled with carbon dioxide, like in a soda stream bottle or a bottle of seltzer. You have these four entities in solution, just like human blood. Now, the second concept is that there's an equilibrium, which means that you've got interconversion of these species into each other, and the concentrations will depend on the pH that the system is set at. So at pH, so what this shows are all the reactions that are occurring. They're interconverting into each other. Carbon dioxide and water forms carbonic acid, which can break down into a proton in bicarbonate, and the bicarbonate can break down into another proton in carbonate. And at pH 7.4, at equilibrium, you have a predictable concentration of each of these. The most prevalent is bicarbonate. It's around 24 millimolar. The next is dissolved carbon dioxide, which is about 1.2 millimolar. And the least prevalent are carbonic acid and carbonate. They're in the micromolar range. But again, these concentrations aren't fixed. It depends on the pH of the system that you're talking about. Now, what about this entity called total CO2? This is what we get back from a comprehensive metabolic panel. And residents, medical students, and fellows erroneously call this bicarbonate, and it shouldn't be. You should, if you're now doing that, you should not be, because this does not refer only to bicarbonate. And the word CO2 is also not a good name for this. It really should be called the total carbonated species in the bicarbonate buffer reaction in blood. So it's really the total of all the four species that we talked about. The most prevalent is bicarbonate, that's true, but you should not be calling this bicarbonate. So the total CO2 concentration, if it is 25, and at pH 7.4, the system we're talking about, then we know the bicarbonate's around 24, the carbonate's 0.04. These are now in millimolar concentrations. The carbonic acid is 0.004 millimolar, and the dissolved carbon dioxide is 1.2 millimolar. So you can see that it's mainly made up of bicarbonate and dissolved carbon dioxide. But the reason also for not calling it bicarbonate is because at a fixed bicarbonate, if you change the PCO2 and therefore the dissolved carbon dioxide in blood, for instance, someone with respiratory acidosis, the total CO2 can change, not because necessarily of the bicarbonate changing, although it will change a little bit because of the equilibrium shift, but because you've raised the carbon dioxide concentration in blood. And the total CO2 is measured by the clinical lab via two enzymatic reactions. Bicarbonate with phosphoenol pyruvate is converted in the presence of phosphoenol pyruvate carboxykinase into oxaloacetate. And then they have a second reaction in the machine, which takes the oxaloacetate and combines it with NADH to make malate with this enzyme malate dehydrogenase. And the machine measures the optical absorbance at 340 nanomolar. Now you might say, well, it is measuring bicarbonate. And that's true, that bicarbonate is the species that combines with phosphoenol pyruvate. However, when that occurs, you get these other reactions occurring. The carbon dioxide and water, when you lower the bicarbonate concentration in this enzymatic reaction, you shift the equilibrium. So the carbon dioxide and water gets converted to bicarbonate, and you actually are including the carbon dioxide conversion to bicarbonate in the reaction. You get a little bit of carbonate converted to bicarbonate too. But basically, as you deplete this in the first reaction, these two reactions are going towards bicarbonate until they're all consumed, essentially, less so for carbonate. So what it really measures is not just bicarbonate, because you're including the conversion of carbon dioxide into bicarbonate as you deplete it. So it is the total in this reaction here, or the total of all these species. It is an absorbance measurement, so you may have heard that if your VLDL or triglyceride level is very, very high, you have very lipemic serum, you can get a falsely low total CO2 measurement from the clinical lab, even though the blood gas machine bicarbonate, the calculated bicarbonate from the blood gas machine, comes back normal. It's because it impairs the ability to measure the NADH absorbance when your triglycerides or VLDLs are too high, and you might have seen that in the literature. It's something that you'll get on an exam potentially, where you have a huge discrepancy. The total CO2 can be 3 or 4, and the bicarbonate is like 20 or 21. And that's due to the inability to measure the absorbance properly in the clinical lab due to lipemic serum. So as far as the relationships here, the total CO2, if we ignore carbonate and carbonic acid because they're in the micromolar range, is equal to the bicarbonate plus the dissolved carbon dioxide concentration. And we can calculate this by taking the PCO2, let's say it's 40, and multiplying it by 0.03, which is the solubility coefficient of carbon dioxide, to get 1.2. If someone has a respiratory acidosis and this is 80, then this will be 2.4, and you'll have to add 2.4 to the bicarbonate, and the total CO2 difference from the bicarbonate will be greater because you have more dissolved carbon dioxide. So remember for the rest of your fellowship, if you can, to not call this bicarbonate anymore from the metabolic panel. Call it the total CO2. So we also measure blood gases. We're not measuring the total CO2. We have different measurements we're making. And what we're measuring is the carbon dioxide concentration in blood with a PCO2 electrode, a carbon dioxide electrode that measures in an aqueous solution the carbon dioxide concentration. And we also measure the hydrogen ion concentration, or the negative log of that. We measure the pH. So there's 2 electrodes in this machine, one to measure the pH and one to measure the carbon dioxide concentration. There's no electrode or no measurement for bicarbonate. However, the machine can calculate the bicarbonate because there's a relationship between the hydrogen ion concentration and the partial pressure of carbon dioxide and bicarbonate, which is called the Henderson equation. It's a non-log version of the Henderson-Hasselbalch equation, but conceptually it's the same thing, that there's a relationship between these three species, two of which we're measuring, so we can calculate the third. And the important point is this is valid whether you have an acid-base abnormality or not. The relationship will always hold. The other reason for knowing this formula is because it represents physiology. The PCO2 represents lung function, and the bicarbonate represents kidney function. Now, one of the issues is that clinically, we don't get the result back as hydrogen ion concentration, and this would be 100 nanomolar. The units here would be 10 to the minus 9 molar. So these are very small compared to all the entities that we just talked about. This is 1/1,000,000th of the concentration of bicarbonate. In that equation, it refers to hydrogen ion concentration or hydrogen ion activity. But in order for you to convert what you get clinically to this, so that you'll have an appreciation of the equation, you need to be able to convert pH 7 to some numbers. So if you just write down 7, 7.1, 7.2, 7.3, 7.4, it turns out that if you can memorize that pH 7 is 100 nanomolar, you just keep taking 80% of the previous number, and it'll work out very close to what the true interconversion is. So 7.1 is 80, 7.2 is 64, etc. And then you can interpolate in between. It also turns out that even though the equation holds, males have slightly different numbers than females do. The hydrogen ion concentration is the same, and the constant of 24 is the same. However, the PCO2 in females is around 38. It's not 40, and the bicarbonate's around 23. Why that is not clear. It is known that at mid-cycle, the PCO2 drops because of progesterone going up in the blood. It drives ventilation. And in fact, that's how clinicians used to tell when women ovulated. They would measure the PCO2 throughout the month, and at mid-cycle, the PCO2 drops. But even in the steady state, not at those times, the PCO2 is slightly lower. So there are not only male-female differences, but there are also arterial-venous differences. And the arterial-venous differences are small. The pH is a little bit lower in venous blood. The PCO2 is a little bit higher. And you could think of this as a respiratory acidosis. So what happens is the reason for the difference is that the cells are making carbon dioxide, and the carbon dioxide then goes into the bloodstream. And when it gets to the lungs excrete the carbon dioxide. So on the arterial side, you end up with a drop in the PCO2 from 43 to 40, and that shifts the equilibrium, the bicarbonate buffer reaction equilibrium, so that the bicarbonate drops a little bit too. It's as if you have an acute respiratory acidosis here, and now you don't have one. You would see the same thing. Now, it also turns out that the venous arterial PCO2 difference varies with the cardiac output, and there's a hyperbolic relationship. As you lower the cardiac output, you make the venous arterial PCO2 difference greater. And if you think about it, it makes sense. As you slow down the flow of blood back to the lungs, then there's going to be more carbon dioxide from the cells put into each volume of blood. As the blood passes to the cells, if you slow that flow down for each volume, you're going to have more carbon dioxide added per volume. And conversely, if the flow is very fast, you're going to have less carbon dioxide added per volume, and so the difference will be smaller. And it turns out that there's a relationship between these two. Let's say this is 3 and this is 5. Just in absolute units, you'll have an answer of 15 here. And the 15 is pretty constant within a given individual. And in fact, clinicians years ago used to, and you can still do it if you want to know whether someone's cardiac output is severely impaired, you just get a venous arterial PCO2 difference. And if it's much different than 3, let's say it's 6, 7, 8, that really suggests you have a lower cardiac output in your patient than you should have. So it's a nice little trick you can do at the bedside, although we typically only get one type of blood, either venous or arterial, not usually both. Now, these numbers, the PCO2 and the bicarbonate, are kept constant, and that's because of input-output, the concept of input-output. There's a production and an excretion that are equal. So why does the PCO2 stay at either 38 in females or 40 in males? And that's because the input and output are equal in a normal human. So, which means that you must have production and excretion. And the production comes from the mitochondria, from the Krebs cycle, and the excretion comes from the lungs. And mathematically, it's around 20 moles a day. All the mitochondria in our body are producing about 20 moles a day of carbon dioxide, which get excreted by the lungs. Just to give you an example, there's 0.16 moles of carbon dioxide in a bottle of seltzer. So it's a much greater amount. So it's the function of the lungs to keep this number constant. And usually we don't get abnormalities on the production side, maybe in people with a very high fever or when the Krebs cycle suddenly increases for some reason. But typically in medicine, the production is the same, and the problem is on the excretion side, people with ventilatory abnormalities. So changes in the PCO2 really represent changes in what the lung does, not changes in what the mitochondria do. Now, what about the bicarbonate? The bicarbonate concentration is also kept constant, and that's the function of the kidney. And the kidney has a different problem. The first problem is that the bicarbonate is freely filtered through all our glomeruli, and it's filtered at a rate of it depends on the GFR and the blood concentration. So if, let's say, the GFR is 140 liters a day in a typical human, you would multiply 140 times 24 millimoles per every liter, and you end up with about 3.4 moles per day of bicarbonate are filtered by all our glomeruli. Just to give you an example, there's about 5.4 moles of bicarbonate in a box of Arm & Hammer baking soda. So it's not quite as much as in a box here, but it gives you quantitatively an idea. It's a lot of bicarbonate. Now, if that bicarbonate was excreted and not absorbed by the rest of the nephron after the glomeruli, in about 4 hours, you would dump all this bicarbonate, and your bicarbonate in your blood would be zero, you can calculate. So it's essential that we have some system that reabsorbs the bicarbonate that's coming through the tubules, or through the glomeruli, excuse me. The second thing that has to occur is the following. Every day from our diet, we make protons on an average North American diet, and it's about 50 milliequivalents of protons a day. And those protons are made by the liver predominantly and get into the blood, into the hepatic vein, and then into the IVC. And the proton combines with bicarbonate to make carbonic acid, ultimately carbon dioxide, which we excrete in the lungs, but now you're left with a lower bicarbonate concentration. It's as if you had started a bicarbonate IV. And this obviously also cannot be allowed to occur. If it continues to occur without anything compensating for it, we just keep every day adding 50 milliequivalents of protons to our blood. In about 2 weeks, you can calculate the bicarbonate in the blood will be zero. So the 50 is just an average, and it really depends on what we eat. This is a chart that people have come up with based on what type of diet you have. There's acid-producing foods like cheeses, egg yolks, and there's base or bicarbonate-producing foods like raisins, spinach, vegetables. And so it really depends what your diet is. The acids, by the way, are hydrochloric and sulfuric acid. The hydrochloric acid comes from aspartate and glutamate, those two amino acids. And the sulfuric acid comes from methionine and cysteine containing proteins. So every day on an average North American diet, we put about 50 milliequivalents into the system. And it turns out that there is a compensation. And what the compensation is that the kidney generates 50 milliequivalents of additional bicarbonate above what it reclaimed from the glomerular filtrate. This is an additional new amount that matches the daily hepatic proton load. So What happens then is the two combine and we make carbon dioxide, and the carbon dioxide is excreted, but this prevents the proton load from dropping the bicarbonate concentration in blood. So the concept here is the kidney is doing two things. One, as shown on the previous slide, it's reclaiming the filtered bicarbonate. That has to occur. And then secondly, it has to generate an additional amount of new bicarbonate to match the daily hepatic proton load. Okay, so let's go back to the blood gas machine and what's measured. Remember this equation. The hydrogen ion concentration is equal to 24 times the PCO2 over the bicarbonate. And that the pH and the PCO2 are measured and the bicarbonate is calculated. Now, some people have the impression that because it's calculated, it's not a valid number or it's an erroneous number, and that's not correct as long as the pH and the PCO2 were measured correctly. In fact, you can check the equation since the total CO2 from the metabolic panel is almost equal to the bicarbonate. It's a little bit more based on the dissolved CO2 carbon dioxide concentrations I showed before. You can plug the total CO2 from the metabolic panel into here, and the right side should equal the left side. You're going to have to convert pH to hydrogen ion concentration, as I showed before, or just do it on your phone. But it's a way of just making sure that the lab didn't make a mistake. The right side must always equal the left side. So let's take a patient now. So now we're in the real world and we have a patient with an acid-base abnormality. We understand now the measurements, but how do we approach the patient? We can look at many things. And the whole point here is to focus only on one measurement, not all the possible measurements, because you could look at the pH, you could look at the PCO2, you could look at the bicarbonate from the blood gases, or you could look at the total CO2 from your metabolic panel, and it's very confusing because unless you have some sort of systematic approach, you're going to be pulling from all sorts of different measurements, and the problem with that is you're going to mix that. You may make the wrong diagnosis, but in addition, you're going to miss mixed acid-base disturbances. So the approach that I'm going to tell you is an approach that looks at either the total CO2 or if you have blood gases, the bicarbonate concentration first. And you can ignore the pH and the PCO2 initially. In fact, you can always ignore the pH, as we'll show. We'll look at the PCO2 next. But so you train your mind when you get these numbers to focus on the total CO2 if that's all you have, or the bicarbonate concentration if you have the blood gases. And you ask your mind the following question: is that value normal, increased, or decreased? So the first thing is to focus on that entity, and then the second thing is to ask, is it normal, increased above normal, or decreased below normal? If the answer is it's decreased below normal, then you have three possibilities, which is the next thing you have to memorize for the acid-base diagnosis. It's either a metabolic acidosis, or it's an acute respiratory alkalosis, or a chronic respiratory alkalosis. All three entities lower the bicarbonate or the total CO2 on the metabolic panel. And you can't tell just from looking at that which of the three it is, although most people would intuitively say metabolic acidosis, but you have to remember the other two possibilities also. Otherwise, you're going to miss these diagnoses potentially. And then we'll talk about how to distinguish the three without looking at the pH. Now, it also turns out that the PCO2 is decreased in all three, so that doesn't really help you. So directionally for all three, the bicarbonate's decreased and the PCO2 is decreased. But the first thing just to train your mind to do is, after you've decided that the total CO2 or the bicarbonate are decreased, immediately you go to the thought that there are three possibilities, and you write them down. And now the goal will be to try to distinguish these three. And the way we do that is to conceptually try to quantify the magnitude of the change in bicarbonate from its normal level, or the total CO2, if that's all you have, compared to the change in the PCO2 from its normal value. And if you don't have the patient's normal values, you have to assume population means like 40 in a male or 38 in a female, etc. And that's what distinguishes these three disorders. It's the change in bicarbonate from it's the decrease in bicarbonate from its normal value compared to the decrease in PCO2 from its normal value. And those changes have to be memorized. And once you know those three acid-base rules or the three predicted changes, you can compare to what your patient has to see which of the three is there. If it's not one of these three, then it's a mixed disorder. So in metabolic acidosis, we have a decrease in bicarbonate and we have a decrease in PCO2. The initiating event is the decrease in bicarbonate, and then we get a change in our ventilation, which some people call the compensatory response, although it's not a great term because it implies that its purpose is to bring the pH to normal, and that's been shown years ago by Medius and others that that's not always the case. You can get a change in the PCO2 as a ventilatory response, and it actually can make the pH worse. Although we're taught in medical school that the ventilation, or so-called Kussmaul's breathing, or what you get in metabolic acidoses, whether they're anion gap elevated or not, that the PCO2 change is to bring the pH to normal. That's not universally true. But empirically, what we see is a drop in the PCO2, and unfortunately, we use the word respiratory compensation or compensatory response, and we'll continue to use that. But you have to know in your mind it doesn't always bring the pH to a level that's better than had it not occurred. And sometimes it's worse. But that change in both of these is known. So and some people use the Winters formula, but you don't have to. What you can memorize is that for every 10 decrement in the bicarbonate, the PCO2 due to the ventilatory response should change by 12. Or if this changes by 5, the PCO2 should drop by 6. Or if this changes by 1, the PCO2 should change by 1.2. So what you have to memorize is that for a given fall in bicarbonate, the PCO2 is going to fall 1.2 times that amount from its original level. So let's say you have a male with a bicarbonate of 24 to start, and it falls by, let's say, 10, the PCO2 would be expected to fall by 12 from its original level. And if it started at 40, it would be 28. So if you see a patient with a PCO2 of 28 and a bicarbonate of 14, that's completely what you'd expect, and you'd call that a compensated metabolic acidosis. Now, what about the concept of anion gap? We divide the metabolic acidosis into whether the anion gap is elevated or not, and this has to do with electroneutrality considerations in any solution. If you take all the ions in a solution, all the positive ions are going to equal all the negative ions. Most of them are inorganic, but some are organic, like IgG is positively charged, so patients with multiple myeloma with a lot of IgG, that'll affect the anion gap. And there are organic anions, such as lactate, beta-hydroxybutyrate, these kind of things that can change the anion gap. But if you do the math, if we are using sodium minus chloride plus bicarbonate to calculate the anion gap, everything else we can call unmeasured anions, which will include phosphate and sulfate. It depends what you want to put on the left side. If you include something on the left side, it won't appear on the right side. If it's not included, it'll go into the unmeasured category. So if you collect all the positive and negative charges, you will get two entities that you can group into unmeasured anions and unmeasured cations. Now, it's important to realize that this doesn't just equal the unmeasured anions, right? Because the right side has to equal the left side. So you also have unmeasured cations, and that will include calcium, magnesium, and IgG. So someone with multiple myeloma with a lot of unmeasured cations, the anion gap actually decreases. That's what you see. And actually what's happening is you have IgG chloride, right? You can't just have IgG. You have to have an anion with it. So on this side, the IgG goes up, and on this side, the chloride goes up. But if you do the math on these sides, you're going to end up with a decreased difference on both sides. This side, it's because the chloride goes up. This side, it's because the IgG is positive and goes up. And similarly with beta-hydroxybutyrate or acetoacetate, there, the unmeasured anions are going up, but they're coming in with a proton, so the bicarbonate drops. So this difference goes up and this difference goes up. So that's a brief overview of the anion gap. And it's important to realize that it's a dynamic situation. So let's say you have lactic acid coming into the bloodstream. It's the anion lactate coming in that raises the anion gap, but it's the proton that coming in that drops the bicarbonate. So the anion isn't causing the metabolic acidosis. It's the proton that's causing it. The anion, though, is coming in with a proton, so it's an indirect reflection that you had a proton load. The anion doesn't come in with sodium or potassium unless you're getting some sort of drug that's an organic anion, like carbenicillin or something that also has a cation, a non-proton cation coming in with it. There you can have the anion gap going up without the bicarbonate changing because you're not getting a proton load. But for endogenous organic anions, they always come into the body with a proton load. So metabolic acidosis, we ask, what is the PCO2? Is it compensated or not based on the rule that I showed you, and what the anion gap is. Now, when you change the PCO2, there's a temporal component to what happens to the bicarbonate, which is why we divide up respiratory alkalosis into acute or chronic. We don't call it compensated or not compensated. What evolved was to use time as the subdivision of respiratory acid-base disorders, also for respiratory acidosis. So it's not sufficient just to say my patient has a respiratory acidosis. You need to say it's acute or chronic. Now, in acute respiratory alkalosis, the same thing occurs as would occur if you uncapped a bottle of Coca-Cola. The PCO2 would drop. And what happens is, if you look at this equation at the bottom, as you drop the PCO2, you drive this reaction towards the left. And what happens is you actually drop the bicarbonate concentration. You also drop the proton concentration, but it doesn't drop as much as the bicarbonate drops because other buffers release protons and keep this more or less the same. This only changes in the nanomolar range, whereas the bicarbonate is changing in the millimolar range. And that's because other buffers release protons because their equilibrium has been shifted also and keeps this relatively the same, although it does change, it does drop a little bit. So acute respiratory alkalosis would be similar to this, where you hyperventilate and drop the PCO2 over about 5 minutes or so. And it's artificial because it's obviously a continuum. You can hyperventilate for days and days, but in the first 5 to 10 minutes is what people are typically thinking of when you say acute respiratory alkalosis, and the bicarbonate drops. So here we have again a drop in bicarbonate and a drop in the PCO2, just like a patient with metabolic acidosis. So if we look at this thought experiment, if we have PCO2 of 40 and drop it, let's say, to some new low level and keep it here at the same level for days, and then follow the bicarbonate, we'll see the following. The bicarbonate will fall initially. That we would call acute respiratory alkalosis, and that's due to a shift in the bicarbonate buffer reaction. It does not require any organs. It's like uncapping a bottle of Coca-Cola. But if we keep following the bicarbonate, it will continue to fall and fall and fall over days until a new steady state is reached, and we call that chronic respiratory alkalosis. Now note, the PCO2 is not continually falling. It's staying the same. It's the bicarbonate that continues to fall, and that's due to events occurring in the kidney, which we won't get into today. If you don't have any kidney function, if you're a patient with ESRD, it always looks acute, even though the days are passing by. So you can be fooled temporarily into thinking your patient has an acute respiratory acidosis, even though they've been hyperventilating for 3, 4, 5 days. And that's because to have a fall in the bicarbonate, you need to have normal functioning physiology in the kidney. And to be able to say someone has acute respiratory alkalosis, you have to memorize the second rule, which is that for every 10 fall in the PCO2, the bicarbonate falls by 2. So if the PCO2 fell by 20, because I'm acutely hyperventilating, the bicarbonate would fall by 4. If this fell by 5, the bicarbonate would fall by 1. And you can see that those proportions and changes are very different than someone with a compensated metabolic acidosis. So if you have someone where the change in the PCO2 and the decrement in bicarbonate fit this, then that's compatible with acute respiratory alkalosis. And then chronic respiratory alkalosis, as I mentioned, the bicarbonate falls further. So for every 10 fall in the PCO2, the bicarbonate would fall another 3. The first 2 is due to the bicarbonate buffer reaction shift. The next 3 is due to the kidney physiology. So the total fall is 5. And it'll stay at 2 again if you don't have, if you have non-functioning kidney physiology. So if you see someone where the PCO2 fell double what the bicarbonate fell, that's compatible with chronic respiratory alkalosis. So knowing those 3 rules is how you distinguish what the fall in the bicarbonate was due to. And notice we haven't looked at the pH. And you don't need the pH to be able to distinguish the 3 or to make the acid-base diagnosis. And the pH must be a given number anyway based on the Henderson equation. Once you've defined what the PCO2 and the bicarbonate are, based on that equation, you have to have a given pH. You can, knowing what the PCO2 and bicarbonate are without knowing the pH, you can calculate that pH. It has to be the number that's measured if the PCO2 and bicarbonate are correct. So again, chronic respiratory alkalosis requires normal kidney functioning and requires days till a new steady state is reached. Notice we don't have any names for what's in between here. We could call this subacute, subacute, chronic, and it is artificial just to take the beginning and the end, but that's what evolved over time. So again, we have if the total CO2 or bicarbonate are elevated, the converse acid-base disorders, we have 3 of them also. So if you have an elevated bicarbonate, it's not just metabolic alkalosis, as people would think. You also have to think of the respiratory acidoses that you divide up into, again, temporally, acute or chronic. And notice the PCO2 is increased in all 3. And that's something that not everyone recognizes, that in metabolic alkalosis, you also have a compensation. Your PCO2 also goes up. Your ventilation decreases, the converse of what happens in metabolic acidosis. So let's say I have a metabolic alkalosis due to vomiting or Bartter syndrome or Gittleman syndrome, whatever the cause is. The bicarbonate will go up and then my ventilation will change and I'll decrease my ventilation such that the PCO2 increases. And that's called, again, a compensation, even though its purpose is not always to return the pH to a better pH than you had before. But it's called the compensatory response. And again, this is the 4th acid-base rule that you just have to memorize. In metabolic alkalosis, for every 10 increase in the bicarbonate, your ventilation will decrease such that the PCO2 goes up by 7. So let's say I started with a bicarbonate of 24 and it went to 34 because of vomiting. I'd expect the PCO2 to be 47. It went from 40 to 47. This would be a male, where the PCO2 starts at 40 and the bicarbonate starts at 24. We don't divide metabolic alkalosis up by anion gap. We divide it up by whether it'll be corrected by giving chloride-containing salts. And notice I said chloride-containing salts, not sodium chloride, because it's the chloride which is doing the correcting, not the cation. It's the chloride which is essential to reverse the acid-base disorder. And you could just give chloride and see what happens. But it was found that if you measure the urine chloride concentration prior to treating the patient to see if it corrects, you can predict whether it will correct, whether you give chloride or not. And if the chloride concentration in the urine is normal, you can give as much chloride as you want and the bicarbonate will still stay the same, such as a patient with Gittleman's or Bartter syndrome or renal vascular stenosis, any cause of why you have an elevated bicarbonate, Little syndrome, whatever it is. If it's not chloride dependent, the urine chloride is normal. They excrete their dietary chloride just like a normal person, and you can give as much chloride as you want. It'll be futile. You'll still have the acid-base disorder. Whereas if the chloride concentration in the urine is very low, then that's a patient who you can predict if you give chloride-containing salts to, the bicarbonate concentration will return to normal. So again, there's 2 things we look at. We look at whether it's compensated like metabolic acidosis, and we look at the urine chloride concentration rather than the anion gap. Now, what about the respiratory acid-base disorders? Again, it could be acute or chronic, and what we have here is the PCO2 going up because of a ventilatory problem. but we find that the bicarbonate also goes up. And again, this is the bicarbonate buffer reaction, which is doing it acutely. If I bubble a solution with carbon dioxide, I'll drive the reaction to the right and create bicarbonate. I'll also create the same amount of protons. However, the concentration of the protons hardly changes because other buffers take up the protons. And so the free proton concentration stays roughly the same in the nanomolar range. It goes up a little bit. And what you see is the increase in bicarbonate. And again, in the first 5 minutes or so, 5 to 10 minutes, we call this acute respiratory acidosis, and it does not require organs, just like acute respiratory alkalosis doesn't require functioning organs. And you're just looking at the function of the total body bicarbonate buffer system. And you can think of it conceptually as the PCO2 increasing and staying there, and then following the bicarbonate over time. Initially, it'll go up a little bit because of the bicarbonate generated in the bicarbonate buffer reaction, and we call that acute respiratory acidosis. And then if you follow the patient at the same PCO2, you're not raising the PCO2, it will continue to go up until a new steady state is reached, and we call that chronic respiratory acidosis. And again, for that, you need normal kidney functioning and normal kidney physiology. If you have someone with ESRD who has an elevated PCO2 that was kept there over days, it's not, the bicarbonate will not keep going up and going up. It'll stay at the original acute respiratory acidosis level, and you can be fooled into thinking that your patient was only hypoventilating for a short time, even though they weren't. So always think of the renal function when you're assessing whether you get the predicted response in the respiratory acid-base disorders. And of course, if it's someone with CKD, then the response can be in between the maximum and the acute level. So that's even more complicated. So for acute respiratory acidosis, this is the fifth acid-base rule. For every 10 increase in the PCO2, the bicarbonate goes up 1. It doesn't go up, it doesn't change as much as it did in acute respiratory alkalosis, where it changes by 2. It changes a bit less. So if the PCO2 goes from 38 to 48 in a female, the bicarbonate should go from 23 to 24. If the PCO2 goes up by 20, the bicarbonate should go up by 2. And again, these changes are very different than someone who had an elevation in both due to a metabolic alkalosis, where for every 10 increase in the bicarbonate, the PCO2 goes up by 7. Very different changes in proportion between these two. So if you see these kind of changes, it can only be acute respiratory acidosis. And then if the patient is hypoventilating for a longer period of time, like someone with COPD, chronic bronchitis, for every 10 increase in the PCO2, the bicarbonate will go up by 3.5. One of the 3.5 was due to the acute buffer reaction. So another 2.5 will occur if you have normal renal function. And if you see this, a change in 10 for a change in 3.5, or a change of 20 for a change in 7, or a change in 5 for a change in 1.75, that kind of thing, that's all compatible with chronic respiratory acidosis and nothing else. And again, we're looking at something that has to occur if the kidney is able to change its physiology so that there's more bicarbonate in the blood. And I won't get into the specifics of how the kidney does this. That would be a large portion of a lecture in and of itself. But just remember that these acid-base rules with the respiratory acid-base disorders apply to patients with normal renal function, just like the compensatory responses in metabolic acidosis and metabolic alkalosis assume you have normal ventilation, normal lung function. Now, there are additional clues that you have a respiratory acid-base disorder that you need to think about when you're assessing a patient. This is a bit more complicated conceptually. Now let's take a patient with a bicarbonate of 14 with a metabolic acidosis. You'd expect if it's a male, the PCO2 would be 28. Remember, it's 1.2 times the changes in bicarbonate. So the bicarbonate decreased by 10. This should decrease by 12. So you come along and your patient doesn't have a PCO2 of 12. Let's say it's above 12, or excuse me, it's not 28, it's above 28. Let's say it's 33, 34. Well, that's a mixed acid-base disorder because It's only a simple acid-base disorder if the PCO2 is what you'd predict it would be. In other words, if the compensation or the ventilatory response was as predicted, then that's a simple compensated metabolic acidosis, simple acid-base disorder. But if the PCO2 is less or more than you predict, by definition, it isn't, you don't just say they didn't compensate appropriately. Yes, that is true. But if you just say that, you're missing another acid-base disorder. Their lack of compensating appropriately means, by definition, they also have, in addition to the metabolic acidosis, they have a respiratory acid-base disorder. So if it's in the red, if the PCO2 is above 28, they have a respiratory acidosis in addition. And if the PCO2 is below 28, they have a respiratory alkalosis in addition. And this confuses people, not so much the alkalosis, but the acidosis. People say, how can your PCO2 be 32, 33, which is below 40, and you're calling that a respiratory acidosis? And the reason for that is it's called a respiratory acidosis because it's above what it should be, not that it's above 40, because it shouldn't be 40 in this situation. It should be 28 in a normal human. So anything above 28 now gets defined as respiratory acidosis. So you can only say that if you know what it should be. So make sure that you memorize the expected response and then go back and look at what the patient has. If they don't have the expected response, then by definition, they have a respiratory acid-base disorder in addition, either acidosis if it's in the red between 28 and 40, and alkalosis if it's between 28 and 20. And it's always a question that comes up, how close to 28 do you have to be? If it's 29 or 27, do you make a big deal about that? And in general, no. We're talking about a value that's plus or minus 1 here, although those limits are not well defined. And in a given patient, it's going to vary from another patient. But in general, if it's 27 or 29, you would say that's fine. That's the expected response. And remember, again, that when I talk about these subdivisions, each of them is divided into two. The metabolic acidosis by anion gap, metabolic alkalosis by whether it's chloride sensitive or not, respiratory acidosis by time, acute or chronic, and respiratory alkalosis by time, acute or chronic. We don't use the words primary or secondary. You'll hear that on the wards all the time. There's no need to say that. If it's metabolic acidosis, you're saying it's an entity in and of itself. And if you're saying respiratory acidosis, you don't call the compensation in metabolic alkalosis a respiratory acidosis. And you don't call the compensation in metabolic acidosis respiratory alkalosis. That's called the ventilatory response or the compensatory response. So when you say respiratory alkalosis or metabolic alkalosis or metabolic acidosis, it's always primary. We never use the word secondary to talk about compensations, which is why you never need to use the word primary. The other concept is these things take time. So in metabolic acidosis, it takes about half a day to a day for the compensation, for the ventilatory compensation to be complete. And so if you don't have the value you'd expect, the 1.2 to 1 or the 12 to 10 ratio, it could be because you didn't wait long enough, and you'll erroneously think there's a respiratory acid-base disturbance in addition. So you have to wait long enough. That's something that people tend not to think about. They tend to think that these compensations occur instantaneously, and it's a very important thing to learn that if it just happened and you were there at time 0, don't expect the compensation in metabolic acidosis or alkalosis to occur instantaneously. Metabolic alkalosis takes a bit longer. And in between, the PCO2 will have changed less than you predict, but it doesn't mean there's a respiratory acid-base disorder present. Give it enough time to reach a steady state. You have to have a steady state before you make a clinical acid-base diagnosis. Acute respiratory acidosis, we talked about, is the first 10 minutes or so of hypoventilation. Chronic respiratory acidosis takes about 3 to 5 days. Remember that bicarbonate is continuously changing. It takes that long to reach a new steady state. And then the same sort of concepts with acute and chronic respiratory alkalosis. And we'll do a few cases here until we reach the hour. So here's a 27-year-old male diabetic. Ketones in the urine were 4 plus. The total CO2 on the metabolic panel was 15. Glucose was 800. Notice the normal anion gap, which is confusing. And here are the acid-base numbers. So again, if someone says to you, what is the acid-base diagnosis? Don't look at all the numbers. Don't look at the glucose. Don't look at the anion gap. Don't look at the pH. Look at the total CO2 from the metabolic panel or the bicarbonate. And answer, is it elevated, normal, or decreased? And the answer is it's decreased. So we know that the patient either has a metabolic acidosis or acute or chronic respiratory alkalosis. It's always three choices. So is it metabolic acidosis? We would expect that if it's compensated properly, that for every 10 fall in the bicarbonate, the PCO2 would fall 12. And we can see that that's what we have here. Now, again, you might say to me, well, you don't know the original numbers. How do you know the original bicarbonate was 24 and the original PCO2 was 40? Don't you need to know that to know what the decrements were? And that is true, but typically you may not have previous levels. So unfortunately, we have to assume population norms. And we're assuming that the PCO2 was 40 in this person before the problem started and the bicarbonate was 24. So, and notice again, the total CO2 is above the bicarbonate by about 1, or roughly 0.03 times the PCO2, which is what creates this difference. This also measures the dissolved carbon dioxide, not just the bicarbonate. So we have a patient with a compensated metabolic acidosis, but it's weird that the anion gap is normal, even though the blood sugar is 800. And the patient is diabetic and they have ketones in their urine. So how could they have a normal anion gap, and why doesn't the patient have an anion gap metabolic acidosis? So the point of this case is to teach an important point about the anion gap. So we have this acid-base diagnosis, but the blood chemistry picture looks like it's non-anion gap, even though the cause clinically looks like it should be an anion gap metabolic acidosis. So we're left with the question, why is the anion gap in the blood normal? And we have 4 plus ketones. We have anions in the urine. Why didn't the blood anion concentration go up? So why is the anion gap normal? And to answer this question, you have to realize that there's an input-output issue here too. Same as with carbon dioxide. So in an anion gap metabolic acidosis, we have protons coming in and organic anions. As I said before, the organic anions are going to change the anion gap concentration, and the protons are going to change the bicarbonate concentration. So it's the proton load which is causally inducing the metabolic acidosis, and the organic anions which are raising the anion gap. The organic anions are not causing the metabolic acidosis. But the point to realize here is that the anions don't just stay in blood. They are filtered by the kidney and handled by the kidney different, depending on whether it's lactate or beta hydroxybutyrate. Each organic anion, after the filtration step, is handled by the tubule differently. And unless they're all reabsorbed back into the blood, your anion gap can decrease because you excreted them in the urine. So it's not just due to the input, it's due to the output also. And with ketoacidosis, the beta hydroxybutyrate and acetoacetate are not well transported. And if you have normal GFR, as we'll show in a minute, based on some data, you can have all the organic anions that are being produced being excreted by the kidney, and your anion gap in your blood will not be elevated at all or very little. So unfortunately, people use the anion gap clinically to assess the severity of the ketoacidosis, and by that they're implying the severity of the production of ketones, and by implication, production of protons, production of proton load. And that is erroneous, because you can dial in whatever anion gap you want for a given production rate by varying the excretion rate. So the extreme would be someone with ESRD, where every anion coming in will stay in the blood. There is a situation where the anion gap does reflect the anion production rate and input into the bloodstream. But again, depending on the excretion rate, you can have any anion gap you want between many patients that have the identical production rate. So please remember that the anion gap does not just reflect the anion load into the bloodstream. And this was realized in this paper from a number of years ago, where they measured the BUN here, but showed, and these people tend to be volume depleted with pre-renal failure and have various degrees of ability to get rid of the ketone beta hydroxybutyrate and acetoacetate. It depends on the filtration of these things. So as you raise the BUN as a reflection of more pre-renal failure and decreased GFR, the anion gap goes up. So you can see here the anion gap dependence, not on the production rate, but just on the filtration rate, which is something people tend not to think about clinically. So from now on, really do that. And if you see someone with 4+ ketones in their urine, it's telling you that they're excreting very nicely the organic anions. And in those type of patients, you would tend to think that they're not volume depleted, either because they didn't have a very severe osmotic diuresis, or they were given IV and returned their GFR to normal. But either of those situations, the anions are going to be dumped into the urine, and your anion gap's not going to go up as much. So the anion gap can be any value in ketoacidosis, remember, for a given production rate. And it depends on the input and the renal excretion. And it cannot be used to assess the severity of DKA in the presence of a decrease in GFR. So we have, again, pictorially, two patients that have the same ketone input rate into their bloodstream. And patient one has an anion gap that's close to normal or normal, and the other patient has an elevated anion gap. Both have the same degree of ketoacidosis, or the same degree of input of ketones. This patient has a lower anion gap because the GFR is closer to normal. They're euvolemic and they're able to excrete the organic anions in the urine, and this patient cannot. So every organic anion that's put into the bloodstream stays there. And then, of course, you can have everything in between. And you'll see it dynamically too. Someone can come in with an elevated anion gap, not with ESRD, but with pre-renal failure from the osmotic diuresis and volume depletion. They may be vomiting. And then you come by and you give them IV saline, correct their hypovolemia, correct their GFR, and you'll see the anion gap metabolic acidosis converted into a non-gap metabolic acidosis. Again, not because you're changing the proton input, but just because you're allowing the organic anions to now get excreted in the urine. Okay, I think we'll do this patient and then we'll stop, and we'll continue in the next seminar, the remaining patients. This is a female in the 3rd trimester. Again, we look at the total CO2, it's decreased. The bicarbonate's decreased on the blood gases. And again, what is the acid-base diagnosis? We focus on either the total CO2 or the bicarbonate. We don't look at the pH, and they're both down. So if they're in the down direction, again, it's one of the three. Is it metabolic acidosis or acute or chronic respiratory alkalosis? And what we have here is a decrement of about 9 from normal. Remember, the normal bicarbonate in females is around 23, and the PCO2 is down by about 18. PCO2 starts at 38. So this is a decrement of 2 to 1, where this fell by 18 and this fell by 9. The only acid-base disorder of the three that cause a drop in the bicarbonate is chronic respiratory alkalosis. It's not compatible with what you'd see in compensated metabolic acidosis or acute respiratory alkalosis. It's perfectly compatible with chronic respiratory alkalosis. Again, a decrement of 18 in the PCO2, and half of that fall numerically in the bicarbonate. And again, we're talking about someone who's hyperventilating, but not acutely for a longer period of time. We see this fall in bicarbonate, assuming the kidney physiology is normal, and numerically it's half of whatever the PCO2 fell from its original level. And this is what we see in pregnant women. And it doesn't have to be the 1st trimester. These are just data in women at 12 weeks, 24, and 38 weeks of pregnancy. You can see that at all trimesters, they have a chronic respiratory alkalosis. The PCO2 is typically around 30, not as low as the other patient I just showed, and the bicarbonate is down by roughly half of what the PCO2 fell. And the thought, again, is that it's due to progesterone being elevated, driving the ventilation. Other causes of a chronic respiratory alkalosis are high altitude. Here we have a very common cause, end-stage liver disease. That's what, again, it's thought to be due potentially to progesterone in these patients with liver disease driving ventilation, although it's one of the acid-base disorders you see in these cirrhotic patients, patients with severe liver disease. And then there's COPD, again, not chronic bronchitis, where you get a chronic respiratory acidosis, but emphysema, where the acid-base disorder is chronic hyperventilation. They get a chronic respiratory alkalosis. But probably the most common on the earth is people that live at high altitude who are completely normal. So, if you go do your fellowship in some renal division that's at high altitude, the normal acid base numbers are not 40 and 25 or 38 and 23. You're always dealing to start with a chronic respiratory alkalosis. Okay, I think I'll stop there. And if anyone has questions, please raise your hand, let me know. If not, we'll see each other again at the next seminar. Any questions at all on anything I've said that wasn't clear? Okay, everyone, thank you for joining. And again, congratulations to all the new fellows and have a great day.